Neither Dr. Bhatt or I have any financial arrangements with the content of this activity, so there's nothing for us to disclose. We're going to talk today briefly about the components of using a team-based approach, particularly for applying office-based Suboxone or Suboxone procedures. So I'm going to go over the importance of using it and why this is a recommended model, and briefly name some of the team members and the roles that those team members could play in an OBOT program. And those responsibilities. And then Dr. Bhatt's going to talk a little more in depth about some of the training and the different components specific to physicians or prescribers. And then we'll wrap up by talking briefly, what can administration or leadership do to support building this team? Because we recognize that not everybody is in a leadership or an administrative role. And so you really do need to have support from those folks to have protected time to work from a team-based model. So hopefully this will be helpful in how you move forward to develop a team if you're not already doing so. So why use a team-based approach? Well, what's recommended is what's called integrated treatment. And so that means that multiple service providers work together. This is kind of the gold standard in most research that says that this is the model for treating not just individuals with substance use disorder, but individuals with serious mental illness and those that are comorbidly diagnosed. And it really helps because with using multiple service providers, you can get multiple needs met in a collaborative manner for the patient rather than expecting the patient to go and get those needs met independently in the community. So it allows them to really receive combined treatment for all of the things that are behind their symptoms. Because we know with substance use disorder, people have oftentimes, the vast majority have some comorbid mental illness or symptomatology that is either behind or exacerbating the substance use. They also have really profound psychosocial needs or deficits. And so being able to regularly coordinate care with all of the individuals that are working with that patient allows us to provide a consistent message about treatment and recovery. And it also allows us to really work together to support that individual, again, rather than only being responsible for one piece of the pie, really helping to meet all of those needs because they're really interconnected for individuals. Quickly, there's a difference in some of the language that we use between multidisciplinary and interdisciplinary. And what we're trying to move towards with the gold standard integrated approach is interdisciplinary. Multidisciplinary is a lot of the work that we do when we get ROIs for other providers, but it's essentially where you're taking care of one piece of the puzzle and other providers out there in the community or maybe in your organization are taking care of other pieces, but you're not regularly working together. That's different than interdisciplinary, which brings all of those different providers from different disciplines or similar disciplines together to the table to share a treatment plan and to implement that plan together. So that means that we're using that same treatment plan to make sure that the goals and the messages are consistent. Some concepts that go with this is recognizing that recovery is more than just symptom remission and more than symptom stabilization. So from this model, it's understanding that recovery really involves like the whole person and the development of new meaning and purpose in their life. So more than just their symptoms are stable or in remission, it's also saying, what does this individual need to do to live a fully engaged and connected life? Because those things is what's going to prevent a future relapse, right? So helping somebody really have established lifelong recovery means regularly talking to them about what's important, that value set. And by including all of the people who work with the patient themselves, and their concerned significant others, that's really crucial for developing that meaning and for helping people to have success in all of those goals. It's also really, really important from this perspective that the treatment plan is the golden thread that follows the patient from provider to provider that there's one treatment plan that's shared and that the patient is the owner. So they are aware of exactly what's in their plan. They're talked to about it regularly. They have copies of it, because if they're not the owner, they don't accept some ownership over that plan, they're substantially less likely to do what's directed in it. So that's really necessary, is that there's a sense of ownership and responsibility that the patient feels around that treatment plan. And this is where the leadership piece is important, because infrastructure needs to be in place to promote team staffing and cohesion, and to allow the team to work together, sharing that one treatment plan. So that's some of, in the clinic workflow, having an expectation that there is protected time for teams to meet and staff patients, and also that everybody knows where that plan is located, and that they can comment on that plan during staffings and during routine clinical encounters and interventions. So every time you document on a patient, that treatment plan should be pulled up and looked at. So every provider working with them knows exactly what's in that plan and has the power to modify it based on that encounter. So what are the components of a successful team? So who's on it? There's really two aspects of the team. There's a core team and an extended team. So the core team is the client and all of the primary treating providers. So the ones that are going to be at that regular weekly or bi-weekly staffing on the patient. So that's, I'm going to go through the core team here in a minute. But also part of the team is what's considered the extended team. So those are the service providers that may see the client much less frequently, but yet need to be aware of that treatment plan or have some role with that. So that's that multidisciplinary component, right? They might work at other agencies in the community. It could be the dentist, the primary care provider. It may also include concerned significant others or family members. So people that aren't at that regular team staffing and may not know the ins and outs of that treatment plan, but they do nonetheless work with the patient, and some communication will be needed. What's the structure of the team? Every team needs to have a team lead or a manager, somebody who, the buck stops here, is responsible for that treatment plan, and the team as a whole. Sometimes they're the primary person working with the client, but not all the time. Every team needs to have a coordinator, or what's called a recovery coach, who's responsible for sort of the logistical administrative components of the team, organizing the meetings, communicating about those meetings, documenting into the treatment plan when staffing takes place, and sort of tracking or recording the various things that are necessary to have a robust and real-time treatment plan. That being said, once we go through the roles, recognizing that it's important to have defined roles on a team, but everybody needs to be flexible enough that if a team member is out, or if you just don't have enough people to meet every role, that everybody on that team can wear different hats. So you need to know what your identified role is on that team, but also be able to fill in when for others as needed to sort of meet all of those components. So now I'm going to go through briefly the different roles that are part of the core team. The team leader, program manager, this could be really anybody who has an independently licensed or an independent license. So it could be therapist, MD, RN, PA, MP, but somebody who's at kind of that level, because they need to, they're responsible for the team formulation, the case conceptualization, and monitoring some of those interventions. So it really should be somebody who has at least an independent license of some kind. And they also are a consistent point of contact with the patient. So this isn't someone who's never seen the patient. This is someone who regularly sees them in some manner. And part of what they're doing in those team meetings is really is coordinating that communication between team members to inform that treatment plan. So they will also have some patient care functions, and that may include conducting support groups or therapy groups or other things. It doesn't necessarily have to be individual contact. Another role is the recovery coach or engagement specialist. We use engagement specialists here at ASAP. That's the label that we use. And this is a really great role for, we found, for RNs and MAs, so medical assistants or registered nurses, but it could also be someone of the level of like a peer support specialist or a community health worker or a bachelor's level social worker, depending on who you have. So this it would require some training to step into the role, but really they're heading up the administrative duties. So making sure that all of the things that need to get checked are sort of done and coordinated, that prior authorizations were done, that the PMP was looked at. They might be regularly looking at BUP logs or looking at those 24-hour callbacks or whatever those administrative pieces are that are regulatory. And then they're also monitoring that when the patient is checked in, that other processes have taken place, vital signs are collected, regular UAs are collected, that self-assessments were administered, PHQ-9, those types of assessments. That screening for co-occurring disorders have occurred and occur regularly, typically at a 90-day interval. They're also part of providing a lot of education to patients. So they have the time to sit down and explain the basics of buprenorphine and Narcan and how to get it, program expectations, different harm reduction techniques, and they can pull in other team members as needed, but they provide a lot of that psychoeducation for folks. And then that psychosocial support is really important, and our engagement specialists do a lot of this. They're really the primary contact for patients that are not engaged with a provider regularly. So especially our less stable folks, they regularly call them. They're the ones that see them when they check into the clinic. They help make community referrals as needed, but they're kind of that regular keeping a bead on where the patient is. Referrals are a big part of that extended team. So we recommend as part of this process, you're not going to be a one-stop shop for all needs. So keeping a list of community referrals in your area can be really helpful because there's a whole host of things that patients are going to need. So keeping a list of how people can get connected to 12-step programs, traditional healers, higher levels of care, crisis lines, needle exchanges, where they can get HIV or Hep C testing, different resources in the community for food, housing, employment, clothing, that sort of thing. So keeping that stuff in mind. We also recommend as part of this team that a therapist be involved in some shape or form. They need to have some degree in psychotherapy, so that could be social work, marriage and family, counseling, psychology, but being able to work with this patient population, and that they really prioritize working on CBT models, so focusing on relapse prevention, motivational interviewing, possibly applying some contingency management or 12-step facilitation. And then a pharmacist is another person who has a role on this team. So they're responsible for making sure that naloxone is available and distributed, patient education is provided on those medications. And then they can also be a leg to sort of that extended team in the community, working with first responders or other pharmacists in the community where patients might be going, where there could be a lot of stigma or barriers in place, and helping the physicians or the prescribers to kind of keep an eye when other medications show up that may be problematic, particularly those that have comorbid chronic pain. So who are those high risk patients? And then lastly, we have our APNs or physicians, assistants, and physicians, and they can play very similar roles. So they're prescribing and administering the medication. They're responsible for doing the physical examination, making sure that the patient is appropriate for buprenorphine, and then helping provide training and education to the rest of the team on those important medications. So I'm going to turn it over to Dr. Bhatt to talk us through some of the specifics to prescribers.
Sounds good. Thank you, Dr. Maley. And a lot of the next few slides, when it comes to the buprenorphine, I've really drawn upon the Massachusetts collaborative care model, which was really the first model that sort of systematically looked at this idea, right? And the reason that this model started to develop is because there was a shortage of providers, of prescribers. And this really was developed prior to the advent of CARA, right? Which allowed nurse practitioners and physician assistants to also start to prescribe buprenorphine. So this is pre-CARA, right? So there was a big shortage. Opioid epidemic was already here. Rates of people suffering from opioid use disorders were rising. Rates of opioid overdose mortalities were rising. So the researchers, the clinicians really started looking at how can we leverage these few providers we have, right? In terms of increasing access. So they really looked at it and they said, well, the best way to do it, just like Dr. Maley's been talking about, is to use a team-based approach. so that the relatively few providers, the prescribers, are doing less work, and the rest of the team members are stepping into other responsibilities that allow them to function to the best of their licensure, their ability, maybe with some additional training. And the hope was that this will lead to increase in patients receiving buprenorphine treatment, as well as actually increase in waivered providers by taking away some of the barriers and providing training. And in fact, this is what was achieved, right? So the team-based approach really showed that not only did the patients go up, but also the number of waivered providers within the state of Massachusetts actually went up almost, you can see, 375% in a 3-year period. And there was appropriately, and ultimately you want to look at patient level data, we saw markedly increased patients who were receiving medications for opioid use disorders. And this seemed to be especially true for minorities. Central to this process were nurse care managers. And nurses are often utilized in this way, as Dr. Maley pointed out, in many other models that have been emerging, right? And what the authors reported is that a team of one nurse care manager plus one medical assistant could see to a total of about 125 patients, right? And if we can actually go back to the previous slide, Dr. Maley, just for a minute. Sorry about that. Thank you. Right, and this is just, this is one slide that shows the importance of training, right? Because again, part of it was this workforce development, right? The nurse care manager might need additional training to step into this role. The MA might need this training. The front desk might need this training. So these were a lot of the things, the basic staff training, right? For reference, along with who should be trained. Thank you, Dr. Maley. We can go back forward. I apologize. And then let's see, next, yeah, we can go to the next slide. Thank you. So this one again, is again there, I included it as reference to show the clinic flow, right? How it might work. Say I'm a patient and our hub team is sort of the collaborative care model team, and I'm going in to seek treatment. So the initial screening would be actually done by the nurse care manager, right? Then the entire team would get together and review the chart, right? The MD would make sure that I indeed have a diagnosis of opioid use disorder, right? Do a physical examination, verify that diagnosis, and do the prescription. And in this, you can see that even the prescription would be generated by the nurse care manager, with the provider simply signing off on it. And of course, the pharmacy would fill the prescription, provide education, ensure naloxone access, right? The induction was done by protocol. And this Massachusetts care model, being several years old, actually utilized an in-office observed induction model. And that was all protocolized, led by the nurse care manager, supported by the medical assistant as well as the prescriber. And then there would be backup visits, right? So the way the visits were set up is that the prescriber would only on average see the patient once every 4 weeks, whereas the nurse care manager would see the patient weekly for the first 4 to 6 weeks, then every 2 weeks for the next couple of months, then go to monthly, then go to bi-monthly, etc., depending upon how the patient was using. And as I already showed, this model seemed to be effective, cost-effective, as well as effective and efficacious in terms of keeping patients in treatment, in terms of reducing their illicit opioid use. So this is really what started us as a nation thinking about team-based approaches. And many other models have evolved. Next slide, please. And this one actually is there for reference, where I've included what the initial screening assessment, again, led by the nurse care manager with special training, what sort of things are included in it. And I've really just kept it there for reference. Next slide, please. And then the key part of this model was training, right? Because the goal is that for the team-based care to function, to optimally, not just the prescriber, not just the nursing staff, but the entire team needs to receive that training. So it included, of course, the buprenorphine waiver training, but sort of buprenorphine as well as substance use disorders, addictions 101 training for all staff. How do you work with individuals who have substance use disorders? Stigma training, dealing with challenging behaviors, right? The entire team to be able to come together, as well as developing policy and procedures, and billing support. So professional can be drawn in to provide this training as needed. A lot of kind of similar to what we're doing, right, in this ECHO. And if you can go to the next slide, thank you. And this just looks into the basic training, again, the reference slide. Before we go to the next slide, I want to bring up a couple of really new things that have come out as we start looking more and more into team-based care, especially in the era of COVID, which has created access problems, its own challenges. One paper that's just come out, it's online publication now. It will be published in the journal Addiction soon. So we'll probably be having new slides on it once it's published and once I can legally share it for our next cycle. So that, the team out of Duke University actually led a physician pharmacist partnership. So they utilized a similar model to this to get patients started on buprenorphine, stabilized on buprenorphine. And once the patients were stable, they were transferred over to pharmacists, right? Under the current federal regulations, pharmacists and pharmacist clinicians are not able to prescribe buprenorphine, which is a major point of contention, right? So the authors, the study researchers were able to obtain a special waiver from the federal government as part of the study so that the pharmacists could then take over the management of these patients who had entered some form of stability. And they followed them for 6 months. And the data is actually overwhelmingly positive. I think, and I don't remember off the top of my head, but something like 90% plus patients were retained in treatment at 6 months. And, most of them, 85% plus, were actually doing well in maintaining abstinence from illicit opioids, right? So another way to think about creatively the team-based approach. Another thing that, again, people are starting to implement, the data is starting to come, are group-based opioid treatment. One of the leaders of it has been Dr. James Berry out of West Virginia, who's one of our partners in this AHRQ funding, right? And they've been exploring how do we really do a group-based model. And other places are starting to explore it as well, where, for example, 20 to 30 patients might be in a room and the group is co-led by a provider, a prescriber, as well as a therapist. Patients are pulled outside briefly for the provider, the prescriber to meet with them, write prescriptions, then the patients go back into group. I know Dr. Jacobson also did that at our clinic, right? So I think people are starting to do it. Data is starting to come out. And as we have more data, perhaps that will become a more viable strategy, as well as best practices about how do we make this more financially viable. A lot of that is starting to come out. So you can expect to see significant revisions to this presentation over the next couple of cycles of our ECHO. So people are starting to think very creatively about this. Next slide, please. And finally, I want to make a note to clinic administrators, right? And the reason being that consistently in literature, one of the barriers that emerges as to why more prescribers don't prescribe is lack of administrative support. So if you are an administrator attending this, great job, welcome, we're glad you're here, right? And really, we want you to support the clinical team. Keep that open communication, right? Address and take lead in coverage issues to make sure our patients will have adequate coverage if someone, as Dr. Maley pointed out, is going to be leave or be out, right? Ensure appropriate staffing, allow time for trainings and continuing education, because that ultimately translates to better patient care, better treatment retention, and better outcomes. And be collaborative in terms of devising those clinical policies and guidelines. Next slide, please. And finally, what all of us can do right now, I think I have a couple of slides on this, but the gist of it being, and I often say this, and we all of us often say this, be an advocate for your patients, right? Help create an accepting, patient-centered environment, do everything we can to combat stigma, work with your tribal, state, national leadership to really advocate for policies that will benefit our communities, right? Policies matter. Policies lead to very real life, experiences for our patients, and that's important. So be engaged, be involved, have a seat at the table, and that's really the kind of the gist. I know we're right at 12:30, so I will stop here. Thank you.